Hello, in this video we're going to review catheter occlusion, a complication of central vascular access devices. So catheter occlusion is characterized by inability to flush or infuse medications, inability to aspirate blood from central vascular access device, or just a sluggish flow. So catheter occlusions can be subdivided into three types. They can be mechanical, there can be a precipitate, or thrombotic. Basically mechanical, it's any kinking in the tubing itself. Precipitates is caused by medications. Medication clog the catheter. Or thrombotic, where it's already the blood factors that cause the occlusion. So we'll start with mechanical cause of central vascular access device occlusions. So the cause can be internal mechanical problem that includes pinch-off syndrome or malposition, and these types are reviewed in my previous video. So it is possible that the catheter tip is sitting against the vessel wall, blocking the ability to aspirate blood. But you can still infuse medications. Simple thing as repositioning the patient can resolve this occlusion. The cause that is outside the body could be the clamp may be closed, and that can lead into an ability to aspirate or infuse medications. The catheter may be kinked, then filter could be clotted, and the sutures that secure the catheter to the body can be too tight and block the aspiration or fusion of medications and fluids. So the second type is the precipitate. So the causes of the precipitate occlusion include inadequate flushing between medications, then infusing two medications that are incompatible, and they can react and cause occlusion. Infusion of medications with high or low pH. By this they're meaning pH high like 9 or low as 5. Some of the medications that have such a pH are phenytoin and amiophylline. Also infusion of lipids. Lipid emulsions causing occlusion by leaving a waxy buildup on the catheter wall. This is more likely to occur with 3-in-1 parenteral nutrition solution, which include amino acids, dextrose, and lipids, and additives in a single container. So common drugs that can cause precipitate formation on the wall of the catheter are, as earlier mentioned, phenytoin, vancomycin and heparin, tobramycin and heparin, fluorouracil, and droperidol, dobutamine and furosemide, dobutamine and heparin. The third type of catheter occlusion is thrombotic. So this type of occlusion occurs when a fibrin and blood components within and around the catheter of the central vascular access device or within the implanted port slow down or disrupt the catheter flow. Accumulation of deposits leads to obstruction of the infusion. Any artificial device, placed in the body, including the central vascular access device, is coated with plasma proteins, blood cells, and fibrin. When the coagulation cascade, through the coagulation cascade, the device is covered by a fibrin sheath as a result of protective mechanism. So the first subtype of thrombotic cause of occlusion is fibrin tail. any layer of a layer of fibrin located on the tip of the central vascular access device. The tail can grow as more blood components are deposited. With fibrin tail, it is possible to administer medications, but aspiration of blood is not possible. The tail acts as a one-way valve and closes the opening of the catheter tip. The ability to flush but not to aspirate of the blood is termed as partial occlusion or withdrawal occlusion. The second type is a fibrin sheath or sleeve. Fibrin sheath or sleeve, a layer of fibrin coats the entire exterior wall and tip of the catheter. When the fibrin sheath develops, it encases the catheter tip. Any solution that is administered can travel retrograde or backwards to the insertion site. This can result in infiltration and extravasation. Infusates may be observed on the skin and under the skin. So the third type is intramural occlusion. Intramural occlusion is when fibrin clot forms inside the catheter. Flow through the catheter becomes sluggish, then progresses to complete occlusion, in which it is not possible to infuse or aspirate blood from the catheter. Frequently, the cause is blood remaining in the catheter after inadequate irrigation or retrograde flow of blood inside the catheter. Also, poor flushing techniques after blood sampling may allow the layer of fibrin to accumulate over time, narrowing or obstructing the lumen of the central vascular access device. And the last subtype of thrombotic causes of catheter occlusion are mural thrombus. So mural is relating to or occurring in the wall of the body, cavity, or blood vessel. So it's not inside the catheter wall, it's more inside the lumen of the blood vessel. This is caused by catheter tip irritation against the inner lining of the vein, is precisely tunica media, and accumulation of fibrin causes the central vascular access device to adhere to vessel wall. Contributing factors can include frequent cannulations and the use of rigid catheters. So signs and symptoms of catheter malfunction can be, again, inability to flush, inability to infuse, sluggish flow, frequent pump alerts that it's occluded, or leaking of the fluid at the insertion site as fluid backtracks along the fibrin sheath. So some of the things that can be done to prevent that would be ensure and verify proper catheter tip placement in the central vascular access device, superior vena cava, near its junction with the right atrium. Then make sure the catheter and tubing do not have any kinks or closed clamps. Assess the suture sites if they're not too tight. Use saline, administer saline heparin technique when administering medication. Flush the catheter with saline before and after medication administration. Know the type of needleless connectors on the end of the central vascular access device. When it's a positive pressure needleless connector, do not clamp central vascular access device until after syringe is disconnected. So you would flush, then you would remove the syringe, then clamp. In negative pressure needleless connectors, With them, apply pressure to the syringe barrel, close the clamp, then remove the syringe. With neutral needleless connectors, clamping sequence doesn't matter. You can clamp at any time, before or after disconnecting the syringe. Filters. So use a 1.2 micron filter to administer a 3-in-1 parenteral nutrition solutions. Now, you can also consult with the pharmacist to help identify causative agents or solutions and avoid potential drug and drug interactions or solution and drug incompatibility. So what do we do if the occlusion did happen? How do we resolve it or treat? So we'll rule out any mechanical causes of the occlusion, such as earlier mentioned closed clamps, kinks, obstructed filters. If unable to flush the catheter, then disconnect and access it again and try flushing it again. You can also instruct patient to change position. It is possible that the catheter tip is against the blood vessel wall, and the position change may result in aspiration of blood. If this is a persistent problem, radiographic evaluation of the catheter placement is indicated. For suspected precipitate formation, collaborate with the physician, PA, nurse practitioner, or any licensed independent practitioner for treatment and orders. The following solution can be instilled into the central vascular access device in a volume that approximates the central vascular access device internal priming volume. This solution is instilled and left in the catheter for at least 60 minutes before withdrawing the solution. So 0.1 and hydrochloric acid can be used to dissolve low pH drugs precipitate, such as vancomycin. Sodium bicarbonate can be used to dissolve high pH drug precipitate, such as phenytoin. Then ethyl, ethanol, ethyl alcohol, sodium hydroxide, and can be used to restore patency to the catheter with suspected buildup of lipids. Now, for suspected thrombotic occlusion, collaborate with the licensed independent practitioner for orders and treatment. So obtain an order for alteplase. Follow aseptic techniques. For inability to withdraw blood or sluggish flow, unclog the catheter and gently instill medication into the central vascular access device. Then for complete occlusion, never push the alteplase directly right away into the central vascular device. So unclamp the central vascular device and unclamp the central vascular device, and while holding syringe vertically, gently aspirate until plunger reaches 8 milliliters mark, then slowly release the plunger. This step may be repeated several times. Idea is to remove all the air from the central vascular access device, create a vacuum, and let alteplase to fill the catheter, that empty space. Afterwards, clamp the catheter and secure the device to the patient and label it "Do not use." Allow the agent to dwell in the catheter recommendations for alteplase: allow to dwell for 30 minutes and then assess for blood return. If successful, discard aspirated blood, flush the central vascular access device with 0.9% sodium chloride solution, and resume infusion as ordered. If not successful, allow the alteplase to dwell for additional 90 minutes and reassess for blood return. If not successful, a second dose may be used. Collaborate with the licensed independent practitioner for obtaining the second dose, or obtain it in advance. So, important thing to mention: agents such as alteplase, hydrochloric acid, bicarbonate should not be used with short peripherally inserted catheters or midline catheters. So do not use these agents with simple IVs. Also, alteplase activates the plasminogen. Plasminogen activates the plasmin, and the plasmin already breaks down the fibrin and stops the fibrinogen from being activated. Also, probably breaks down the fibrin too. All this leads to degraded products, and that's where we get the D-dimers. So the alteplase, TPA, the dosing is about 2 mg/ml, and you might use only 1 milliliter. Instill that, the recommendations is to instill into the occluded central vascular access device and let it dwell. So this concludes this video on catheter occlusion. I hope you enjoyed this video. Thank you, and I wish you a great success.